when the public sector it does not provide enough outpatients, obviously people will go to the private, and there's always going to be duplication of care. So when we look at some of our data, when people do not have a chronic disease, the split between public and private primary care is roughly what we expect, about 70 to 30. But in the population surveys that were done, not by us, but by the government, when they have one chronic disease, 80% or 85% of the population go to the public, and 50% use both public and private. So there's a duplication of care, and there's no coordination. There are gaps in care, and that's why once people have a chronic disease, the affordability is a question, right? So I still remember in Singapore, in the early days, the Medisave, you could not use it for outpatient care. I think they've now changed it, understanding that once people have chronic disease, the affordability becomes an issue, because it's not the drugs, but the ongoing treatment and then the complications that are required. So the outlays are sometimes not predictable. So people feel more comfortable going to the public sector, and then when they need to, they then also go to the private sector. So these are the instruments that we talk about. So when you look at the management of the system, the governance system, obviously in terms of hierarchy in the public system, you have a whole hierarchy in terms of directly accountability. But how do you then engage or influence the private sector? Is really through these policy instruments, through persuasion, information, through taxation. Just now I mentioned about the giving tax rebates for people to do certain things, expenditure, which is what we're familiar with, and regulations. And each of these will be talked about in the respective sessions. So the policy strategies are established at the macro level, are executed at the meso and micro level, right? So even when you do a reform, you need to see what's going to happen in the organization. So you can't just say that we purchase this and expect things to happen in the field. So that's why I talked about the strategic purchasing in terms of then what you want to buy is a more integrated product. So how you design your purchasing tools, and then how you pay people, right? So they are the enablers, and of course they are also the tools that you can gauge the private sector in terms of integration, right? So I just want to cover some of these different modalities, which are quite interesting. Some of them, as I mentioned earlier, are from experiences in the US. US is quite interesting because they have got a very, very market-driven system, multiple providers. But you can also learn from them in terms of how the tools that you have can be used in the context of your own system. And then particularly when in countries like Singapore, Malaysia, and then our jurisdictions like Hong Kong, where we have a very, very large private sector. And we're really trying to get them to work, like Dr. Lee talked about. We're trying to change the whole system. Because we're very ambitious in Hong Kong, the government wants every one of us to have one family doctor, right? So how do you then engage the private doctors when many of them are in the Indian practice? And for chronic disease management, we know that that's not a very good model of care, right? So you really, for chronic disease, you need to have good practices, right? So those are things that one can look at. What are the organization tools that one can use, right, to enable this better integration? So you need to look at the different mechanisms that you can use. So the goals of integration is really to provide the linkage, but you need to have governance structures and mechanisms, right, to coordinate the services. So the organization forms, which are quite interesting, you can have mergers, corporatization, right? So in Hong Kong, we corporatized the public system. As you heard from Dr. Lee in 1990, where before that, we had 16 different providers, right? We had the public provider, under the government, that was the large provider. And then we have another 15 providers of NGOs provided, and many of them with religious backgrounds. So these were 16 provider organizations that we merged and corporatized in one day, on one day. So it's quite a high-risk thing. So just now, our colleague from Indonesia saying that you should be piloting. In fact, Singapore did that. They corporatized hospital by hospital over a period of time. Hong Kong decided to do it overnight. Right? So we took all the 30 over hospitals from 60 providers, merged them, corporatized them, and took over just overnight. And that was quite a massive exercise. And it was quite interesting because I was the head of the organization that took over that practice, and the government also. And after taking that over, before we took over, the board said that we wanted to see visible improvements in 2 years, right? So you can imagine the amount of work to merge, even in terms of the administrative things. So on day one that you took over the hospitals, everyone had to have they had the same terms and conditions. You had to have the same rules, the same administrative procedures. Even the way that you pay your suppliers is going to be different. A lot of the laws had to be looked at because the government exempted itself from many of the legal requirements. So many of the public hospitals did not meet safety standards, but because they were under the government, they were protected by the law. But when you corporatize, you had to make sure that all those were within the law. Otherwise, you'd be a laughing stock. You can imagine that government said we're setting up this corporatization, supposed to improve the quality, and on day one, you can't even pay your bill, right? That you don't meet the legal statements. So it's quite a massive exercise. But corporatization is quite powerful to merged organizations. So that was a merger, corporatization and merger of all the bodies. Obviously, something that it's not something that you can do very easily, but those are certain options. And some people have already done it sometimes for, like just now, the suggestion to pilot it in certain districts. So you could really experiment and pilot and look at models that can build up. So those are tools that one can use, and they're not necessarily that one should not think about them even in your own system, right? But those are certain things that one can look at. Joint ventures, of course, the difference between corporatization and joint ventures is that usually for joint ventures, the corporations will continue their own independence. So they then enter the agreement to have a joint venture. So it's like forming a third organization where you share the risks and benefits. So the organization then continues to be able to be independent and do not carry the total risk. So that's also one model that one can look at, because that joint ventures could then be the vehicle for more integrative care, or they can do certain things that they can share some of the resources. Strategic alliance is something that I was quite interested in, because I think that would be quite a good tool. Because in Hong Kong, Dr. Lee did not talk about that, because we in fact piloted the district health system 4 years ago. I'm doing the evaluation, and we just wrote them a final report just now. It's being they have looked at it and they had some comments. But the district health system is in the 18 districts in Hong Kong, and they started 4 years ago with one, and then had a second one, and then they rolled out those later on. So we were asked to do the evaluation of the first two district health system, and the model was quite interesting. The model was really a district health system, but in a center, and quite limited in terms of the resources. But they had a model of two things. One was the connection to the community, so health promotion. The second is what they're now doing to do health assessments and then disease screening. So what Indonesia is doing now. So for patients that are at risk to having that health assessment, have risk of diabetes and hypertension, they are then referred to a doctor for health screening, right, to confirm whether the person has hypertension or diabetes. Yeah. And then after that, for them to get the chronic disease management. And through that, they have a network of doctors and allied health professionals. So there are physiotherapists, occupational therapists in the whole network. And these are the so-called network service providers. But because these individuals are independent practitioners, so they're not groups. So there's a doctor A in this location, and the physiotherapist in another location, dietitian in a third location. And when we did the evaluation, we find that there were no referrals, very few cross referrals. Because these networks, it's just the concept of having people calling it a network, but there's no relationship between the different parties. There's no agreement between the parties. There are no protocols. So there's nothing to link them together. So there's no network, right? So networks are things that need to have some mechanism. And of course, these tend to be very, very fluid, very dynamic, very, very organic, right? And it's only when there's an interest, when they share an interest, right, they will come together, or there's an incentive for them to do it, right? They will do so. So these networks are interesting. So, but then when you look at that, if you're really trying to get to group these GPs together, then you need to look at. We suggested for them to look at strategic alliances. But what do you mean by strategic alliances? Right? How can they be strategic, and how are they different from the networks? Right. So that's quite interesting, because I think those are, to me, quite useful tools, right, for government when you want to change the system and you want to engage the private sector, rather than engage them individually, to engage them in groups, because they're not. Doctors don't like to be managed, right? Because there are many of these HMOs, group practices, but some do not want to be tied in, as it were. They want to continue with their old model. And therefore, then there are also hybrid models, and then selective contracting, which I think Professor Lockstone will talk about. So horizontal integration, links across sectors of similar service, vertical between different levels, and temporal, quite important, because we want to have continuity of care. So these straight lines refer to a variety of inter-organization relationships. So you see that when you look at this, it's the organization integrity, independence, which is important, because for this, they are like an option, because people don't want to give up all their organization independence, right? So they then work with some other organization, have some agreement. So that's why they call them strategic. So why are they strategic? And how do these alliances work? What are the conditions for them? So the potential events, of course, you can increase accessibility and quality of care. There can be economies of scale and cost control. You can gain in resources, because if strategic, that is to our benefit, or you can share risk. So we have straight lines to bid for. Let's say if government wants to, now they want to do this co-care scheme, right? So with this, they can share the risk. So rather than my individually just carry all the risk, I can share a risk because I form a group where we have some agreements, and it obviously can be more influencer. So it's greater organization in interdependence, but you still maintain substantial independence and autonomy. So we have within the straight alliance, we agree certain things, but organization, I'm still distinct. So I'm not giving up my own autonomy to the extent. So it depends on, obviously, the formality of the arrangement. So you need some formal. It could be legal contracts or written agreements, right? So it's a whole range of things. So with the legal contract, it's even more important. But sometimes if government wants to purchase services from a straight alliance, the government will require, because the government might want to hold these alliances to be accountable. So like what we're trying to do in Hong Kong with this very ambitious district health system, that government wants to have the whole system eventually to be under this you heard today, that they're going to have passed laws about the Primary Care Commission. In the blueprint, there is it that they want everyone in Hong Kong to have a family doctor. I don't know how they're going to do that. Certainly, I'm not going to register. I didn't tell Dr. Lee that. Why should I go to register with a family doctor? What's my incentive? Why should I do so? Okay, but But then because if government uses the financing tool, the contracting, right? So government may want to contract. So that's a very powerful tool. And if I contract with groups rather than individuals, then the individual will have to form alliances. They need to have some contracts, and government also require them to have contracts, right? Because if government wants to do it, they need to hold the groups accountable. So imagine how can government go in Hong Kong? We have like 15,000 doctors, right, and about 8,000 in the private sector. How can you hold 8,000 doctors accountable? How can a contract with 8,000 doctors and keep them and manage the contracts? How do I know what they're doing? So whatever you have, even if you have an information system, it's not so easy really to look at the quality of clinical care. But if you contract with groups, then it's easier because you help hold the group accountable. So Singapore does that. Singapore, in fact, has been contracting with networks, and the networks are in Singapore are called networks, but they're really strategic alliances because they're formed. I think they're formed by through the company ordinance. So the Singapore government, when they purchase care, primary care from the private sector, they in fact, I think 5 years ago, I remember that they said that it would help them form these groups. So you can then hold them accountable, because if I contract with you, I need to make sure that the product is delivering what it's supposed to do and the quality is controlled. So then you hold the groups accountable, in which case then they might have to have a more legal basis, right, to hold them accountable. So these trade alliances will very much depend on the government systems in terms of what the incentives for them to do that. In America, because they have a very decentralized system, so the accountable care organizations they provide services and funded by Medicare and Medicaid, which is government. As you know, Medicare is for people aged over for the elderly and for people with disabilities, and Medicaid is for low income, the indigent, right? So those are very powerful things. So they now want to contract for integrated care. So the accountable care organizations then form strategic alliances. So the hospitals might form alliances with the GPs, and they have some agreements where they share in terms of the risk, and then provide care for that population that they do. Because they have got to have tangible, they have commitments. They need to contribute financial resources, manpower, time, and things. Complementary, the skills and resources among them, whether they are complementary rather competitive, the involvement of different parties, the coordination, the risk and certainty, and the alliance. The most important is the mission. The greater need for formal agreement and commitment, the greater the risk for the organization. So the key factors when they form an alliance during the phase, during the formation and partner selection, they look at the complementarity of the partner, the compatibility, and the commitment. And during the design, equity sharing or ownership, contractual provisions, relationship governance, and then obviously you need to manage it even after the alliance forms. So those are things that one can look at if really one is keen to really use this model of organization integration, right? When you talk about complementarity, is to extend the partner's resource contributes or capabilities the other lacks. So when you look at a network of doctors, obviously you can have a geographical distribution, or you could really look at working with different disciplines. So how you complement one another for the product they want to provide, and how compatible it is in terms of the working styles and cultures of different partners. So if you have maybe the same professional training, that's easier. If you have worked together, you belong to the same college, it might be easier. The commitment, how committed people are, and then in terms of contributing resources and the time for those to work, right? So in the governance design, the equity ownership, so incentive for each partner to commitment made towards the alliance, there's the management of contingency. So you need to have look at the equity ownership structure and the provisions made in the contract, on the mutual rights and obligations, interactions, termination or education. So these would be things that are quite important, and they probably need to be either in agreement or certainly in a much more legal on a legal basis if you're really going to be contracting. The relation governance is really the goodwill and reliance that you build up in trust. Right? So you need to, even after formation, you need to continue to coordinate, because it's not something that these alliances need to be worked on. So it just means that just because you got married doesn't mean the marriage is going to stay. You can divorce. So you need to work on it. So the development of the roles and tasks, the more formal structure and the decision-making ability, feedbacks, and continued development of trust. So you need to look at the formation stage, and then you need to look at the things that will hold the network together, the alliance together, and then you need to how to maintain that. So those are quite interesting models that need to be looked at, especially for chronic disease management in the future. Because Dr. Lee was saying that they wanted in future to contract with groups of 5 at least. Right? So how would that work? So if they're very loose networks, there's no agreement, it's very difficult to hold them accountable. So some of these models can be looked at least if they have the agreement among themselves. They don't have to form a separate body, but they could still have some agreements, and then the contract would be holding the group accountable. Right? So networks are very loosely defined, do not require commitment, as said. Much coordination is needed for the organizations, because in our study, we're looking at, because the district health center was supposed to work with the network providers. Of course, it's quite impossible. If they've got like 100, 200 network providers, how can they continue communications with them? How do you build up the network relationships, right? So there's no relation between the network members, and the network depends on the center to do that communications. So you need to look at how can networks work, right? So some of the mechanisms include navigation. So like you're trying to navigate that this patient has hypertension or diabetes. You navigate it to these doctors in that locality, and then you navigate them to the allied health. That's what's being done. But it's very, very difficult to do that, because patients also have a choice, right? And patients, you have all these providers. I can't just steer it to one, because the other provider will say that you're not being fair. Why are you navigating and sending patients only to one and not to another one? And then you still need to have the patient give the patient the choice. Right? So obviously you need to have some coordination, and then obviously if there's some network members that have the same ideas, they want to group together, then it works. But of course, when there's no relationship with network members, it's quite difficult to start this meaningful engagement. So it's really a choice which honors involved activities, identification with the network, cooperation required, negotiation within the network, adoption of ideas, attitude. So these are some of the network-related mechanisms which need a lot of time to work. But as for a system, right, if you're trying to integrate it as a system, then the networks will not be the main role. Because if you really want to have a more integrated mechanism and a systems aspect, then the networks do not work. Right? But then there are so-called hybrid models. So in the strategic alliance models that they have in accountable care, they have what they call hybrid models of associate network physicians as so-called wraparound. So they have organizations, especially if these are large provider organizations, they have a big presence in a certain locality, but then they want to extend their coverage. So they will then engage. They will then have some network physicians that are part of the system. So that's why they call them wraparound, right? So they have hybrid models, primarily of strategic alliances, but with network arrangements as well. So these are quite interesting things, and certainly those are viable models that one can look at. So in Hong Kong, we have these groups, medical groups, that are going to bid for these government contracts to provide chronic care, right? So they could also then work with a lot of the GPs in the round that do not want to be part of a trade alliance, and they could be part of that network. And the advantage would be then then the contract would be primarily with the strategic alliance. And the strategic alliance would then have the responsibility of making sure that the network doctors meet the standards and play a complementary role to their own needs. Because then you leave it to the strategic alliances to find these to complement. Maybe there's certain gaps, certain areas that they do not have services, or certain types especially that they don't have. Then they could then recruit some of these network doctors who do not want to belong to a group. So these things are not mutually exclusive. They're quite interesting models that one can look at in terms of the evolution of the system. Infrastructure is important. Co-location, very important, because we're suggesting in our report to government that they need to look at co-location, right? So because government is now, our primary care group is very, very ambitious. And they're going to take over all the previous clinics from the Department of Health, not many, 18 district health centers, look at the total resources, and then using those resources to see, because there are a lot of these clinics that the government used to run themselves. So those could be used for co-location of multidisciplinary teams. So co-location would be, at least people have the opportunity to sit there together to work out multidisciplinary joint workings from professions of different types of health professions. Can also have shared service there and for referrals. So in many systems, as you know, in primary care systems, they get the specialists to go there, right? So then the integration between primary and secondary care is facilitated. You have a much better understanding. So when people work together, there's a physical presence, then you can sometimes resolve some of the, because as you know, the real person communications, it's sometimes much easier to resolve some of the conflicts and some of the misunderstandings. So when people are there together, then they can at least talk to one another and have a much better understanding. So look, the infrastructure mechanism can be quite useful, right, to facilitate integration. Professional integration, very important. So you can have group practices where people group together. You have so-called professional communities of practice, but these are looser. They are people that feel that's important for us to meet certain standards. So these will be people like with the professions that want to be able to improve the quality of care, so they get together. But these are quite voluntary. And then alliances of health professionals. Functional integration, the back end management, finance, information systems, very important to enable you to integrate, and it facilitates decision-making and accountability. Right? Normative is when people have worked together, they share the values you work on, shared work practices, prioritization. So this is part of that, building on the trust and working relationships. And very important is what actually happens at the patient level, right? So all those things are well and good, but just because there's organization integration doesn't mean that where it matters that there will be integration of the product for the patients. So mechanisms of integration would be develop a clinical guideline for patient care. Multi-clinical teams with roles and responsibilities defined. Integrate the patient record shared by different disciplines and providers. So those are important for clinical integration. So it includes the problem is, of course, then having all these, you still need to connect with the patients, right? So we have not discussed, early on, we talked about some of the issues, but we did not discuss about the patient's access and the patient's perspective, the patient's behavior, right? And that's quite important because we need really to connect with the patient. I think you heard about the drugs that are not taken, that we dispense to patients, and very often it's not consumed, simply because we think that instead of interacting with patients, we just give them drugs. So the patients are now very happy when they see a doctor and they go out with a big bag of drugs. So in Hong Kong, we have a lot of these multi-prescriptions, and I think the studies all over the world have demonstrated that in fact half the drugs that are being prescribed are not taken as prescribed. So there's a lot of waste, right? So the connectivity of the patients, the understanding their roles in self-management is quite important. So we need to see their roles, because without the patient's connection to the system, whatever you do doesn't count, there's no value. So it's important in terms of the continuity of care and comprehensive care. It's what the patient, that's why the patient-centered perspective, the connection in terms of what patients' needs are. So some of these things can be done through channels for ongoing contact with patients. Care navigators, I think you heard from Indonesia about the community care workers. They're really the care navigators. They support people. So we're also suggesting that in Hong Kong, for the district health system in future, they train volunteers who can help the patients navigate the system. Can also help in terms of doing patient education and supporting patients in terms of the lifestyle changes. So that's also a very important part of chronic disease management on the community side that, in fact, many of the integration systems do not look at. Because really, the lifestyle changes are not things that easy. I think you just looking at all the different types of fats for new diets, you can really understand that that's the single most important thing. Diets, exercise, right? Smoking, alcohol consumption, those lifestyle changes are very difficult to sustain. So the support of the community, the health behaviors, how do you enable people to change lifestyles, because it's important, the self-managed support. So those are things that we need to look at. They're not done by health professionals, but by some of the people in the community, the volunteers, people who are trained to do it. So they're quite useful to look at some of these other caregivers and supporters that are not necessarily professional. So patient assessments are quite important for the design of comprehensive care, according to patients' preferences and expectations. So this is one tool, patient assessments. You can in Hong Kong, what we've done now in the district health center is to do, when they're now trying to recruit people to go to the district health center to do a health assessment, right? So they do health assessment. Okay, I'm my time up. Health assessment. But the other part which is important is on the hospital side. Hospitals are very bad at doing discharge planning. Yeah. I don't know whether there's any system that you can tell me that, because I've been very critical of the hospital authority, that the only discharge planning which is done by geriatrics, right? In the medical wards, they're so busy. So they just tuck the patients out when they don't have a bed, right? So after 4 days, we are short of bed. Then the patients have got to go home. So there's no discharge planning, right? They just discharge. So I'll be very happy if the colleagues here can tell me that is happening as a system. So discharge planning is a good tool because it really makes you look at what patients' needs are. And that's where you really need to see, because without an assessment, how can you provide comprehensive care, right? So we only look at from our perspective in terms of the medical or clinical side, and very limited in terms of what patients' preferences and needs are, right? So that's, to me, those are quite important tools for clinical integration, the connection to the patient. And of course, some of these tools that people don't talk about, the patient assessments and discharge planning. So connectivity, very important. Do we need to connect the patients? But it can be by self-managed support, electronic and patient side. So now there's a lot of these innovations. In Hong Kong, we have got this HA Go that provides information. So the tools are there. So care navigation, case management. Right? Case management is very expensive, but only for patients who have of complex needs, right? So they can facilitate continued care, discharge planning, coordination of the physical and social environmental needs. So we talk about the health and community engagement, shared decision making, and self-management. We talk about patient assessments already. And relationship continuity, very important. Okay. Yeah. This is one example of horizontal integration in one of our hospitals in Prince of Wales, just next door, where the geriatricians are working with the geriatricians are working with the neurosurgeons. So they now for neurosurgical patients after surgery, they have rehabilitation care where the geriatricians co-care the patients with the neurosurgeons. So they have a communication, they have set up a mechanism for communications so that after discharge, they will go to the geriatric training program. So this is just one example of the integration, both horizontally and vertically in transition to rehabilitation care. Right. So these are things that one can look at, but they are only for a certain group of patients. Right. So I'll stop here and right. And Siripan, you want to have a hi? Oh, I met on my. Oh, okay. Right. Oh. Okay. All right. So I'm sorry I went a bit long.
So we'll have lunch first. Lunch is in the foyer. Again, there's washrooms on this floor and also on the foyer. So when we come back, we'll reconvene in the seminar room for our next presentation and the concurrent sessions. 1:30, 1:30. Yes.
Oh, yeah. Right.
係有代表沙田醫院係，不過
咁我再可以揾個房嘅秘書夾咁樣咯，或者我喺 email 嗰度會再推翻。我哋時間係會嚟一嚟，我都明冇咗，即係。
up from the ground floor to a weekly session on the role of the private sector. Following from the morning session, if you still be with those of the presenters in the morning, you will heard that each country has its own health system design, and every country are in Asia Pacific countries. So this is Asia Pacific. I asked our network member and EK, how can we actually be able to present to you for the role of the private sector in Asia Pacific region? I have only 30 minutes. Even when one country, 1 minute, that's not enough. No, we have more than 100 countries. But actually, in the Asia Pacific country, they do share some similarities in terms of the private healthcare. So when you think back in your own country, you can look at, for example, some country like Thailand, talking in terms of hospital care, is a public dominated system because the public own allow 80% of total hospital bed, leave only 20% are the private hospital bed. But in terms of primary care, more than 60%, they are all private provider. For the drugstore, of course, almost 100% are the private drug stores. Laboratories outside the hospital, all of them are owned by the private sector. For the MRI or CT scan services outside the hospital are all provided by service, right? By private services, right? So in that you can think, now we are going to present to you for the role of the private sector in Asia Pacific region. But look for the time. I'm not sure that I can go for the challenges for integrated healthcare. If not, I will follow tomorrow. I still have with you for one session on hospital PPP. But again, this time we put primary care and hospital PPP in Thailand. I will do my best. So this is the learning objective, hoping that at the end of the session, because I cannot take this out, at the end of the session, you will have some understanding the key, suddenly UHC, universal health coverage challenges in the local context, define the roles of the private sector, understand the problems the health system could confront for a primary care-led integrated healthcare system. Even though in this session did not put the primary care-led integrated healthcare system, but in the morning session, we are always looking at the primary care. So I think that the best to benefit you is try to link in the morning session to this afternoon. And what are the gaps and challenges encountered in the engaging of the private sector for health system transformation to a primary care-led integrated healthcare system? I think this with you because you are going to work in the group work. That's why we arrange chair like that one. And some of this is your group question that you have to work at the end of at the end of today. Work in the group work. And head down. Doesn't move. This is in the morning on conceptual framework for engagement of the private sector for primary care for health system goals. So do you look at this in at the left box? UHC components. I think that in the country with I think that the UN SDG goals, one of the goals to achieve UHC right? So this is on the USC component, right? Population cover, service packet coverage, etc. This is your support to your health system goals. How to achieve this goal? Assessment, right? Assessment of what? Assessment of your health system. Look at the role of the private sector. And then this is on in the morning that EK already present to you and discuss with you on the government policy tools and mechanism. And the last one is on implementation and monitoring. So for the rest of another 2 days, we are going to go in the box. This is outline for today. First, maybe we can discuss briefly on the key health issues in the region in Asia Pacific countries, the role of the private sector, private financing and provision of the health services, achieving universal health coverage, engaging private sector in the mixed health system, and what challenges in engaging the private sector for health system transformation to a primary care-led integrated healthcare system. Oh. Now, this is some key issues in the Asia Pacific region. In your own country, you have something different from this one that you would like to share with us, right? Changing epidemiological and demographic profiles from communicable disease to non-communicable disease, right? To aging society. In Indonesia, you are the young country. Philippines are the young country. You are not old like Thailand yet. I'm one among that represent the old age group, right? We have in Thailand we will achieve 25% very soon. Aging, demographic profiles, emerging diseases, COVID-19, for example, following from SARS, right? H1N1 or avian influenza, and then etc. I just backward. So we look for perhaps we have to confront with a new emerging infectious diseases. With the high income country or developed country, they never think that they will face a problem of the communicable diseases, right? When you look that, they are concerned on NCD, cancer, hypertension, right? Heart disease, all of that. But they never think that they are going to have that a big issue, the big pandemic of the infectious disease. We cannot deny that infectious disease still with the world, with our world society. Never end. It never be end. And disparities within and across countries. Of course, 5 countries in the morning session, they are different, right? They are different. And so we deliberately, like EK said in the morning, comprehensive accessibility, coverage, continuity, quality, person-centered coordination, accountability. And the most important that I'm health economist is on sustainable financing. When you integrate healthcare, you have to think in terms of the health financing system as well. How can you integrate that with your healthcare delivery system? For me, the health system composed of the 2 main subsystems. One is for the health financing system. Another one is on health delivery system. When I think in the term of designing on the health delivery system, I think how to design on the health financing system as well. So integration will be not success or not sustained without discussing seriously on how to sustain it financially. So this is what private health sector, comprising all providers and financial sources which exist outside the public sector, right? Whether their aim is philanthropic or commercial. Like Thailand is very much on commercial. But Indonesia, I heard from Professor Laksono that you have some form of not for profit. I don't know how to differentiate between non-profit or not for profit. I think that there is no non-profit organization. It's not for profit, perhaps. Not for profit, you can earn profit, right? There's nothing wrong with that. Everyone work. What is your objective of, I mean, that when you look at your lifetime achievement, what would you like to achieve? One of that is your, for what? Your, a little bit on your prosperity, like you can live on yourself, you not rely on other things. In my time when I was in the student, someone told me, Siripen, when you at least at 60, if you have saving about 10 million baht, you will be okay. Like now, it's not okay. It's not okay. Because of, for example, healthcare costs increase very much. So it's not enough. Even though I'm with the Civil Service Medical Benefit Scheme Thailand, still not enough for me to pay on my own healthcare cost. Right? So have to think about that. Aging society is a problem as well. Right? And this is on private health sector, can be individual and organization that are neither owned nor directly controlled by the government and are involved in the provision of health services, can be classified into subcategory like for profit, not for profit, can be formal, can be informal, can be domestic and international. And almost all the country have mixed health system, right? And goods and services provided by both sector, public and the private sector. Even though the country has private dominated system, but you still have public provider. Thailand is public dominated system for hospital. We still have private provider as well. It's mixed. In terms of the finance, we have with the private financing source and we have public financing source as well. It's a mixed health system, right? And health consumer requesting these services from both sectors, not just only for a public one. So if we look in this form of the private sector involvement, this is the type of involvement. Can be payers or financiers, can be providers, can be suppliers. And this is an actor, private health insurance companies, charities, can be private hospital and clinic, private doctor and nurse, civil society organization, or charities. Supplier can be pharmaceutical companies, supplier of medical equipment. Actually, I plan to just only focus on providers, but I think that it's very difficult to talk just only providers. Sometimes we have to talk in terms of the payers or financiers to achieve universal health coverage scheme. And you cannot deny the importance of these suppliers, right? Who are your own suppliers? Many countries, private, are your supplier for your own health system, not a public one. So this is the role of the private sector. Role of the private sector in health remains subject to much debate in each country, especially within the context of achieving universal health coverage. There are two reasons for this debate. First, diversity of private sector encapsulated in the term of what you mean by private sector. I said can be for profit, can be not for profit, right? And multiple and complex process is in achieving UHC. So in consensus, the private sector will play an important role in future health system and in achieving UHC. And this is addressed by ADB, Asian Development Bank, in some years ago. They said that it's not possible for the country to achieve USA without engaging the private sector. If the private sector include the supplier as well. And this is the role of the private sector, ideological system strategy and prevailing ideological role of the private sector. In the view of economists, actually I want to spend, but it had to spend 10 minutes, then I skip market failure. And public health specialists. Public health specialists are very much concerned on equity. I heard EK said many times, equity. How many of us concerned on this term, equity? Every one of us? Oh no, no one don't want to talk about equity. Are you okay with your health system is inequitable in terms of the healthcare allocation or in access to healthcare services? Everyone concerned, but it's very challenging to set out the indicators to measure this inequity. Inequality, you might be able to measure. Inequality in terms of the health might be not equal. For example, some of the disease between male and female, maybe it particularly for male, maybe particularly for female. Breast cancer, right? Majority is female, but someone said to me that they have an example, breast cancer for the male as well. So that's why biologically it should be on with the female, breast cancer. So something is not equal. That is by genetic. So it's not wrong with that. You're not going to make it equal. But some inequity, for example, under 5 mortality rate among the poor and non-poor. If it's so much different, you think that is inequity. What about if it's high together, poor or non-poor? The under 5 mortality is really very high. That is not okay. But if both poor and non-poor has a very low of the under 5 mortality, so you think that your health system performance, is the best, right? But if you leave some of the population, subpopulation suffer from accessing to the healthcare or in terms of their health status, so that is not okay. Like your health system performance is not. Public alone might not be able for you to utilize the resources that is maybe very limited. You might have to engage the private sector, but how to engage them? Pragmatism, right? On terms of feasibility and consequences. What the system role of the private sector? Be able to identify critical issue in system performance in the context of national goals, values, and priorities. Like define roles of private sector in contributing to goals of UHC. Develop and implement program to engage the private sector. This is we look in the overall system role of the private sector. So strategic role of the private sector is, why is the private sector's role strategic? One, integral of our health system. This is talking in terms of in country with a private sector in the general economy, right? Influence on access, equity, quality, cost effectiveness, and health outcome. Or in the key, it's becoming like the key resources for the health system and potential capacity of the health system and chronic disease burden. Right? And this is the potential contribution to achieve SDG, Sustainable Development Goals. Increasing productivity and creating jobs, right? So we deliver it through public-private partnership. We are going on this public-private partnership, perhaps not very much on private sector engagement, and responsible corporate governance and citizenship contributing to policy design, advocacy for the goals, and corporate philanthropy. So that is on the potential contributing of the private sector in achieving your SDG goal. The role of the private sector can be by supranational, is like international organization. I think that in the country, you may have the role of the international organization. Some country might have more role of international organization. Some country might not have much on that role. Can you give me an example of international organization who have much role is like supranational in your own country? Indonesia, you have many, right? You have many. I'm not sure now that you still have it, but you still have, right? But it's supranational for the international organization or transnational enterprise or global health foundation and civil society. You can name in your own country. The government, national is government, can be explicit, implicit, or by default, or divided by market or civil society. So this is the role of private sector in health system in Asia. Can look at this. Private sector provide more than half of all health services. Important for primary care service. Provider provide some to majority of secondary and tertiary hospital care. This is for profit. Private sector much larger than NGO. This is the first group, right? This is the country. If you're not in this group, tell, because this is some years ago group. And group 2, private sector is small, providing less than half of health service. Right? NGO and FBO provide a significant proportion of private sector healthcare. And group T, private sector exists in specialty area like dental care and within structural arrangement in which government is an active partner, is a partner with the private one. Can classify into group 1, 2, and 3. So in summary, role of the private sector can be health financing, source of finance, can be direct provision of healthcare, right? Can be production and distribution of medical equipment, supplies, and pharmaceuticals. Education of health workforce. You have private education, right? Services or university, right? You have medical school, private one, and the public one. Thailand, majority of the medical school in the public is a public medical school, but we do have now with the private medical schools and nurse that include dentists, pharmacists, and public health as well. R&D or transfer of knowledge, right? Or provision of capital for investment, right? Let the private invest and public operate. Is a private investment. Because public do not have their own first to set up cost is so high. So we might have to engage the private sector as a private investor. Intermediaries like insurers. This is on public-private financing system. Public can be taxation, general and levies, and social health insurance. Private for non-public is like this: user fee or co-payment, private health insurance, employee provided benefit or loans and debt, equities and investment, and philanthropic contributions, right? This is the model for healthcare system models of healthcare, right? Beverage or Bismarck model or national health insurance or out of pocket. In Thailand, we have all of this, but in your country, majority of you are with beverage model, socialized medicine, or Bismarck, like funded by employer and employees, privately delivered. Right? Or in case of national health insurance, publicly funded and privately delivered South Korea, Taiwan is in this. Out of pocket, individual pay for own care, like rural areas of India or South America or China. Is it out of pocket? This is models of healthcare. In Thailand, we have share all of this. Okay? You can think in your own country. Majority of you are in which type of the models of healthcare. And this is the, for example, social health insurance is Japan, South Korea, and Taiwan. Before we put Indonesia in social health insurance. But later, Indonesia said that no, you are UHC, Universal Health Coverage, after the year 2014, right? With the presidential campaign, UHC achieved. So, but before we put Indonesia in social health insurance, because you have contribution scheme. And social health insurance based mixed system like Philippines, right? Private in this group of the country, private hospital function as part of the health system. If it's operate as part of the health system, you can engage, right? Private hospital engage in the health system through social health insurance. You have some contract with them. Or public hospital may be corporatized and compete with private hospitals. I think in Malaysia, you have corporatized hospitals in only one. I'm not sure now. And historically, private hospitals predominate in this group. Tax-based correction like Thailand, Hong Kong, or Malaysia. We put Malaysia here as a tax-based correction. Medisave for Singapore, influenced by markets and driven by government policies. Public-private financing and delivery in healthcare. You can look at this. Delivery is in a column, and in horizontal is public financing and private financing. You can have public delivery and public finance, right? Public delivery and public finance, right? General taxation, social health insurance funding of public providers. You can have public delivery and private financing, require user fee, co-payment paid to public providers, or informal payment paid to public providers. You can have informal payments, right? If you have that, because by regulation, you need not to pay, but some patients, they feel gratitude to that provider, and they may give some fruit, something, some to the healthcare, because informal payment. Private delivery and public financing, right? This is social insurance funding with private delivery network, or pool of general tax funding used to fund private delivery network, or government contracting out of specific services, or private delivery and private financing, out-of-pocket payment to private providers, or private health insurance reimbursement of public providers. You can think in your own country, you are in which is the majority part of your health system. And then think, how can you engage the private sector? If you are in this, is that easy or not to engage the private sector to a public to achieve the UHC of the country, right? Or here, right? So you have to think in that in terms of this setting. So I can skip this one for private financing, private, oh, time's up. Private provider and governance and leadership. This is Asia diversity of health system. I took this information my own and took many days to collect because it's different resources. This is in the year 2019. So you can look in your country. This is on diversity of the health system, total health expenditure as percent of GDP, public expenditure as percent of the GDP and the private expenditure. We look at how the role of private sector. So we are going to look, this is more than 60% private expenditure as percent of the total health expenditure, right? We have Myanmar, Bangladesh, Cambodia, Nepal, Pakistan, India, Laos, PDR. Between 40 to 60%, Philippines, Vietnam, Sri Lanka, Indonesia, Singapore, Malaysia, Timor-Leste, and People's Republic of China, Mongolia, Republic of Korea. Thailand is with this country, Fiji, Bhutan, and Maldives. Because for Thailand, now the private expenditure as percent of the total health expenditure less than 30%. This is a big paradigm shift for the Thai health system since we start UHC in the year 2000. This is life expectancy at birth and total health expenditure as percent of GDP. Just look, just that if you want to improve your performance of the health system, the total support that you use indicator life expectancy at birth. For the high income country, there are over 80 years, right? You can look at that, right? Republic of Korea, New Zealand, Japan, Germany, and Australia. For the country in Asia like China, India, Indonesia, Thailand. So this one is not rich life expectancy at birth at age of 80. Suppose that we are going to improve our health system to achieve that. How much more money that you want? Look at in terms of total health expenditure as percent of GDP. You can look in the high income country. They spend more than 10% of total health expenditure as percent of GDP. So are you be able to spend that amount of money? If the people live longer, because of what? At the old age, people use by statistics that the visit to the hospital is perhaps 2 to 3 times of the productive age group. And this is Asian experience. Philippines, Korea, Singapore, and Thailand. Like this is number bed in public hospital as percent of the total number of hospital bed. And this is the general government expenditure on health as percent of the total expenditure on health. You can see that. For Thailand, for here, governments pay more, but in this, the number of beds in public hospital as percent of the total number of hospitals still as high as this month. For Singapore, in this, you can see that. This is in terms of positioning your country in terms of the healthcare spending and the share of the public and the private in providing care. This is Asia Pacific private hospital bed in percent of total hospital beds. Have the South Korea, India, Bangladesh, Philippines, Malaysia, in this. You can see that. This is private hospital beds in percent of total of hospital beds. Like Philippines, about 50%. Malaysia, 25%. Thailand, just 20% are private one. Indonesia, Indonesia is less than Thailand in terms of the private hospital bed. And this is for the WHO region. Private sector deliver a significant proportion of healthcare service in most WHO region. You can see that 40%, 57%, or 62%. Emerald 62%, Zero 57%. WIPO is about 40%. That is private sector providing a significant proportion of healthcare service. And this is look in terms of public and private distribution, in terms of inpatient and outpatient, The yellow one is a private outpatient. The green one is the public outpatient, right? You can see that. You can see that it's much more of the private distribution for 5 minutes left for outpatient services. And this is the sort of care. Look at in terms of the private health sector is a source of, for example, in South Asia, 80% of the healthcare in South Asia is provided by the private one. And this is the reason for consulting the private sector provider. Because ease of geographic access, they might distribute geographically shorter waiting period, flexible hours, or greater availability of staff and drug, or increased confidentiality and higher technical competency. And evolving role of the private sector in health system in Asia, we can find all of this. Financing, capital investment, insurance provision, entrepreneur and intermediary, governments and regulator. Regulator is very important. You don't think that only public can be the regulator. Actually, private can be regulator as well in the health system. This is the role of private sector in the mixed health system. Private health sector engaged in Asia and Pacific. This is on the review from WHO work, summary of information exchange with private health provider country. This is 6 countries that I take out. India, Indonesia, Bangladesh, Cambodia, Laos, and Philippines. The blue one is documentation policy exists. Dialogue with the private sector. This one, no regulation or system exists. This one is no relevant information found. This one is no relevant. So you can say that there actually some countries have policy, but no dialogue. Formally, no dialogue. But in policy, you may have national health information system that includes private providers, policy, but no dialogue, meaning that you're not really implement it. And this is the overview of policy and dialogue of private sector engagement in health in the 6 countries. Like this one we found, this one we found, and this one. So majority of them is like this. For the private health sector or private sector mentioned in National Health Strategic Plan and National Health Policy, we found in 6 countries. We found only 3 countries here that consultation with private sector, with drafting the National Health Strategic Plan, right, and National Health Policy. Only 3 out of 6. So we have all of these on specific objective for private sector engagement, we found. But only Philippines had national policy for engaging the private health sector. You can discuss with our Philippines. What about this? What about their policy that they already have national policy for engaging the private health sector? None of the 6 countries has a dialogue formally, right? None of them. I know, I always finish. And this is the summary of financing in 6 countries. So you can see that Indonesia has this like experience in service contracting of private health sector, right? And experience in voucher scheme, like in Hong Kong as well, have this one. This one is no regulation. You can look in that. This is to give you an overview of Asia Pacific country. We have different in the term of engaging the private sector, formally or informally, right? And this is universal health coverage. You can look at this Q. You already know about this Q. So this is just only to give you on, if you want to access in your own country, this is metric for understanding market size and importance of the private health sector. You can set this is as your indicator. You might have your own indicators, but this one is like number of private hospital, number of private pharmacies in drug sellers in terms of in this. This is some indicator in this metric. I think I found this one is quite useful for the country to understand, to access in your own country in engaging the private sector. Now, I will skip. This is the dashboard. Nowadays with AI and with the big data, always have the dashboard. But this one is good to compare to you on average of Asia Pacific, low income or high income in Asia Pacific. And look in your own country on this status on out-of-pocket payment or health spending. Your position in this. So this is health expenditure per capita. And health expenditure by type of services as well. This is 5 types of private sector in mixed system. Can be dominant private sector, can be private sector complementing universalist public sector, or high cost private sector heading a stratified system, or highly commercialized public sector undergoing reform, or stratified private sector shaped by low income and public sector characteristics. There are different types of this. So each one has a different way to engage the private sector. This is the key finding. And what are the gaps and challenges encountered in the engaging of the private sector for health system transformation to a primary care integrated healthcare system? I will talk about Thailand tomorrow when I go to the primary healthcare in Thailand and hospital PPP. Today, I would like Laksono now because I don't want to take you a much more minute. Okay, thank you so much.
Okay, thank you, Prof. Sriban, for the interesting introduction of the private and public financing. Okay, or no, public and private services. Okay, now I have one opportunity to this actually is not presentation, it's more a workshop on how the health system governance mechanisms and the public-private financing. Okay, so I think everybody is joining a table, and then we can work from this table during my presentations. Okay, so these are the things that we will discuss about health governance and then health financing principles, about revenue for health, pooling, purchasing, and payment mechanism. And this is the thing that how the financing in healthcare as a macro policy that this morning we understand from Professor Iki about the macro, meso, and micro. So we can look at the way of influencing how the macro can influence the micro system. But the point is that the reset can be good or bad. And somehow in the result is also some crime activity can be derived from health service operations, crime against the law in the micro level. And that means, have you heard about fraud in healthcare? Fraud, is there any in Hong Kong? No, but in US, almost 3% of the Medicare and Medicaid budget is fraud. It's used by fraud people and becoming like a crime organized activities. And the FBI is involving in this fraud preventions and what it calls like deterrence and eradication. So it is very serious violation of the law. Yeah. Okay. So Back to the framework by Prof. Ike. So I will start with governance policy instrument, modalities, and mechanism for integrations. And in this instrument, using the governance, financing, and after this, taxation and strategic purchasing. And this afternoon, we discussed about this national government and public-private financing. And then this is the graph by Prof. Ike this morning, that from the macro to the micro, okay, and we have some understanding about the policy that using the framework of WHO on health system building blocks. And this session is how to, what we call is link the logical flow of macro policy into micro situations in here, access, coverage, quality, and safety here. And then how this kind of activities can improve health, responsiveness about the satisfaction of the community, and then social financial rights protection and improve efficiency. And all of these indicators started from the micro system. So this is the big theme of my sessions about how the macro system level will influence the meso and micro level through some government policies, and especially health financing. And this is that I said that it needs good governance for preventing negative impact. Yes. Okay, let's start with the health governance. If we look at back to the issue of what the governance is about, leadership and governance involves, ensuring strategic policy framework exists and are combined with effective oversight, regulations. Yeah. So we have to have like very, very strong regulations. And if you look at in the sectors, health is the same with aviation. So airlines industry is very highly famous of safety standards because we cannot fix the plane if it is already fly. So safety is very, very important in the aviation industry. And then also coalition building, and then regulations, attention to system design and accountability. So everything is concerned with safety and quality. And then who are the actors who interact each other? So the state, we have the state, government organizations, and then the health service providers. And these are the things that we discussed. Prof. Siriman already mentioned about the public and private organization. If we go to the private, we will have the so-called for-profit and non-for-profit. In the US, mostly non-profit, although some company for-profit also work in the hospital services. In Indonesia, most of the hospital, the private hospital now is becoming for-profit company, limited company. And then also we have the unions, professional associations, and then also networks of care or services. And if we go to this private organization like the Hong Kong Medical Associations or the British Medical Associations, and this is also related to how the links between government and these associations. Okay, and then the citizen. This is the place for the NGOs or civil society that maybe they have organizations, and then like trying to protect the equity. So watchdog for health insurance that trying to press or to pressure the equity issue to the policymakers, and then also some of the NGOs working in AIDS, in cancer, and many diseases. So how the good governance then? So this is very important that all of the responsibility, authority of many players or actors can be in harmony. So the policy can be used for maintaining quality of care and providing for organization, management, and planning. A well-governed service is clear about what it does, how it does it, and is accountable to its stakeholders. So every actors of the health system, the government, the providers, the community, they know each other, they work together, they don't fighting each other. Okay, they have trust to each other. So this is like a utopian situation, but this is the things that we have to achieve for the good governance objective. We cannot have a good governance if there is like a distrust between the government and community, or between community and hospital services, or maybe the three parties also fighting each other. It's not good for a country. So that's why we need arrangement. Yeah, how the interdependencies between organizations, and also how to make this arrangement becoming integrated to deliver high quality, safe, and reliable care and support. So the ultimate goal of the governance is back to the issue of health services, quality, and also safety. Yeah. That's why when implemented effectively, good governance creates a culture. So a culture of accountability, transparency, and patient-centeredness within health and social care organizations. So this is the theoretical aspect of good governance. And I think we do understand that not every aspect in the real world can be ideal as in the paper, on the paper. So we will see. I think it's different in every country situation. So discussion, who are the state healthcare providers and the citizen? Can you identify, please? Any comment in your country? Who are for example, the government in my country? That's this morning, Prof. FK mentioned about the decentralizations. We are decentralized country, but not like the US. They have like a state government, or in Australia, we have provincial government, we have the district government. They have the political leaders elected, not appointed by state government. But in China, you don't have any election for the mayor, no, in China. But in the Philippines, it's very strong decentralization. The mayor is elected by the local people. Is that right? Is the Philippines? And any Filipinos here? Oh, from Maya, right? From Maya. Yeah, is that? So mayor in the Philippine city is elected, yeah? Yeah, by very, very tight election. No? Or depends city, yeah. But it's political election, yeah. The same in Indonesia, but not in China, I think. Is there any China, from China delegation? Oh, from China? Oh no, China, mainland China. Is there any from mainland China? Prof. Ika, is there any participant from mainland China? No. No. But how in Taiwan? Taiwan is election or selection? In Taiwan. In Taiwan, Chinese Taiwan. Yes. Election or selection for a mayor is it in a city? Election. Okay, election. Maybe only in China is selected by the party. Indonesia, before the reformation in 2000 yes, the mayor is appointed by the local parliament that is also appointed. Yeah. Okay. So who are you can identify in your country? Okay, let's go to health financing principles. So this is one of the blocks in the WHO health system framework financing, and the policy intent of financing should be specifically designed to, one, provide all people with access to needed health services. So all of the health services of sufficient quality to be effective. And then ensure that the use of these services does not expose the user to financial hardship. And then provide fair compensation for health workers across providers, and ensure the sustainability of financing through public and private resources. So this is the policy intent of health financing. these are at least 4 objectives that we have to achieve. Yeah. And then William Shaw, professor from Harvard University, he coined about 3 functions of hedge financing. One is revenue collections, pooling, and then purchasing and payment. And this function will be identified by you and in a table later on. But actually, the revenue collection is how to raise sufficient and sustainable revenues in an efficient and equitable manner to provide individual with both a basic package of essential services and financial protections against unpredictable catastrophic financial losses caused by illness and injury. So again, this is the objective that's so, I don't know, broad. It is possible to be achieved or not. It depends on the country, maybe economic situations. And then pooling, manage this revenue to equitably and efficiently pool head risk. Okay, so the budget, also the source for finance, will be channeled to some pools that we will train later on, because if you don't describe it by yourself, maybe it's difficult to understand what is the pooling mechanism. And then purchasing and payment. This is the function is to assure the purchase and payment of health services in an allocatively and technically efficient manner and fair for health workers. So not only for the citizen, but also the medical doctor, the nurses, all of medical and health personnel, they have to be, again, satisfied. It seems very easy to be spoken or to be presented, but maybe it's so difficult. Yeah. How to satisfy millions of doctors in China or hundreds of thousand doctors in Indonesia for practice, and they have enough income for doing his professions. It's not so easy. Okay, so the policy option for the public or private financing. So this is the number 1 that Professor Siripan already mentioned, that there are so many variety in the world. Okay, like this one about the GDP, you can see that China GDP development is so big increase since 2000. The red one is Indonesia, also we increase. Yeah, Australia, India, Japan is flattening the GDP. Japan is becoming dangerous in terms of too many old people. They don't work so much, so GDP is not increasing, so flattening in Japan. The tax revenue percent of GDP that put in can be collected by tax system is different in the high income country like Australia. The tax revenue is about 25%, 20 to 25% from GDP. But for the middle income country, usually it's low. Like in Indonesia, this is not good data, but from 2009 is like this. So although our GDP increased, but the tax collection is not so as fast as the GDP increase. Yeah. Okay, China is increasing. Yeah. And then the current health expenditure percent of GDP. In general, Japan and Australia have the highest rates of percentage of health expenditure, yes, current of GDP. So the rich country usually like this, yeah. But the poor country like Indonesia or maybe the Philippines, not the percentage for health is not high. So that's why we have problems in financing health services, because not so much expenditure in GDP, and the GDP is not as high as in developed countries. Yeah. And then this is the point that about the domestic general government expenditure. This is very important, whether we are relying on government spending or private spending. But most of the country trends relying on public spending, especially during the COVID-19 pandemic. So if you look at the 2020 data, it's like this, all becoming increasing. Like in Indonesia, we have a very sharp increase of government spending for COVID. But some of the spending resources come from loan from the World Bank because we don't have enough cash for dealing with the pandemic. So we have to borrow from the World Bank and some other lenders. Okay, this is the interesting issue. And the other way around, that means the domestic or the private health expenditure is becoming going down. Okay, but this is the big question for country like Indonesia, that we have the economy of Indonesia, for example, is actually is depending on private financing. So it is the policy, is it right that we are relying on government spending and in health? That is very important. Okay. Okay, so now please identify the resources for health financing in your country. Okay, can I use this? Yes, blank paper. So let's start with some work. Yeah. So you have to work in your state or state. So please can you look at the camera? No? So we have one is the government funding or public funding, and then private funding. So the draw is to office in your state. Yes, like the paper.
Kalau yang Zoom dari sini.
Oh, nggak kelihatan. Nggak bisa. Oh, okay. Okay. Yeah. Yeah. Oh, oh. Yeah, okay. Okay, let's write one box like this. This is government funding, and this is private. So now the question is, what are the sources for government funding? From the tax or from non-tax income of the government in your country? Do you have like state corporations? Okay. Or maybe your country is relying on loan? You know, so the government funding. Corporation, state corporation, loan. Okay, so please write on in. Oh, not only listening, but you have to write. You have a blank sheet, no? So this is the old school of doing things. Yeah. Because we will use this until the end of my session. Yeah. So please write down. No, you don't have pen. Yeah, you don't have pen. You can discuss. No, yeah, I think everybody can use if you want to have. Yeah. Yeah, you can use it. So in one table, maybe you can identify one example, maybe Hong Kong or Indonesia or whichever even. Yeah. So one. Oh, I think that's the way. So this is parent, not like that, but government funding and private funding is parenting. So for example, for the private, we will have the out of pocket, like okay. Out of pocket like this. Not into that. So this is only the first function is the financing first, not yet the pooling. So what are the sources? Okay, finish because we have a limited time. We have to finish at 3:15, only 30 minutes to go. Okay, so from this point,
Halo, selamat siang Bapak Ibu semua yang hadir daring. Siapa yang ini online sini ya?
Selamat siang,
Baik.
Dr. Lika.
Oh ya, sip. Kirain ini nggak masuk. Oke, selamat siang semuanya. Ya, ini saya baru pertama kali muncul di sini. Di sini ada Dr. Zikri, Dr. Muriandono. Ini Pak Aryan ya? Apa kabar Pak? Ada Dr. Yesi hadir luring juga. Ada Elia Edres, saya Ibu J, Pak Agromiko, Ibu Heni, Bu Lailatul Izzah, Bu Nova, Bu Nur Laila, dan Bu Nurul, ada Bu Tati Haryanti juga. Nah, ini Profesor sedang menjelaskan polling. Nah, nanti sambil ini memang ya kita baru pertama kali mencoba model pelatihan ini. Ada yang ingin diklarifikasi kayak Bapak Ibu dari sesi yang tadi pagi. Ya, oke, baik. Kalau misalnya belum ada klarifikasi, ya silakan Bapak Ibu mengidentifikasi tadi ya ada 3 hal. Tadi kan membicarakan tentang pooling, revenue collection, pooling, dan purchasing. Kalau di Indonesia itu sebetulnya dari mana saja sumber pembiayaan kesehatan. Bapak Ibu bisa googling. Nah, bisa coba googling, kemudian dicari
The BPJS, they have 2 types of revenue from the government and also from private. But the government is used for paying the services for the poor, like in the US. Medicaid, for example, is used for paying the sick poor families. Okay, but for the middle class, they have to pay by their own. So that's why this morning, Prof. Aziza, it mentioned that Malaysia is also introducing like not commercial, but private financing from insurance and then put into one insurance scheme. Yeah. But it is not happened yet. Yeah. In Hong Kong, there is no social insurance by the government, but I bet in Hong Kong there are many commercial health insurance. Is that commercial health insurance?
Yes, it's only accounts for about 10% of health expenditure.
10%, yes. Okay. So this is the policy option of pooling. the pool for purchasing preventive care. Okay. Okay. Any comment in this revenues and pooling? Oh, so you can look at this kind of graph to define this is the pooling. Pooling one. Most of the finance in your country. In Taiwan, only one for the insurance, same with Indonesia, and you have also MOX or DOX, Department of Health or MOX in Taiwan. With of Health and Welfare, yes. It is also pool, yeah. But different with the health insurance. The MOX and welfare is a pool for preventive financing. Is that right? In Taiwan? Yeah, it's not cumulative. No, the MOX, the Ministry of Health. What is the function of MOX?
The function actually is to basically develop overall policy and like oversight all the different departments that relate to health policy, and including the National Health Insurance Agency, which is supervising the utilization and the formation of the National Health Insurance.
Yes. But who finance the prevention of prevention, like primary care, immunization? Which ministry financing that?
I think the entire finance coming from the Singapore NHI.
Also, immunization as well. I don't know. In Taiwan, who finance immunization, for example? Vaccination and promotion
from the government, government provide the finance.
Yeah, but which department? Which
deliver the service.
Okay, so Ministry of Health. Mostly prevention is financed by MOX. Okay. Reproductive care mostly is financed by insurance and by some commercial insurance or out of pocket. Yeah. Okay. Are you following my points? Yeah. Okay. Okay, let's go to the third for the purchasing and payment function. And this is the things that influencing micro level directly. So from this space, then we go to the provider. Is in micro level, okay, and then it is controlled or it is organized also by financial arrangement. How to pay the hospitals and also how to pay the doctors. What do you think? Is it important or not? Purchasing and payment. Very important or not? Very, very, very important. It's not only important, but I think in every country, payment and purchasing is very, very important. Whether it will influence quality of care. What do you think? Before I explain. Is there any evidence that the behavior of medical doctors is influenced by economic incentive? Yes? Yes or no? Or doctor is a noble profession. He or she doesn't take any consideration of financial incentive. I will work as Mother Teresa, like in Calcutta, you know, Mother Teresa, or Florence Nightingale in Italy, yeah. No? Or I work as the same as profession. And if I can, I have to have like a big income, but more time for pleasure. You know what I mean? I can work only 6 hours a day, but I can spend my weekend for 3 days. That is the point. Everybody loves to do that. Yeah. High income, but a lot of time for using the money. Is that right? Have you met anybody that I will work 24 hours a day, 7 days a week? No. So, doctor is ordinary people. Okay, so let's go to this purchasing and payment of function. And the issue is equity, quality, efficiency, and access. And we have some policy option on purchasing and payment. A is allocating resources using planning and budgeting system. So this is happening usually like in the BP system. The hospital is paid by annual budget. Yeah. Okay. Or maybe the spending is decided 1 year before, something like that. And then the B and C, this is more for the pool in the health insurance. It's paying the hospitals and health profession and the doctor based on some of the financial arrangement. It's rather complicated, but it is happening at the moment, and this is again influencing the behavior of the people at the hospital. Okay, let's go one by one. What the A, allocating resources using planning and budget system. This is an ex-ante system. You know that before the program is happening, the planning and budgeting should be done. Okay, that's why we have like annual ritual of planning and budgeting. At the end of the year 2023, we already know that next year we will have a budget about $1 billion for our hospital, something like that. This is the ex ante. And then that means can incorporate equity and efficiency consideration. So because we know that in some like in UK, the sum of the allocation using formula. So the deprived areas, they have more budget than the metropolitan, for example. Yeah, this is the thing that very, very common to reduce the inequity across the region. Okay. And then we have also paying the hospitals and health service organization, not using the global budget or annual budget planning. One is fee for service payment from out of pocket for private healthcare and hospital. So this means the out of pocket is directly go to provider. So it's like if you have the money, you can go to the most expensive specialist, for example. And I think it is still happening at the moment. Although we have the social health insurance in Indonesia, but we have still the way of doing the things in the old school. Yeah. If you have money, if you are rich, you can buy the best service of the best specialist in our country. Is that right? Using your own money. And there is still a market for doing this. There is a point. Free for service. And then if we go to the tax, okay, and then also the premium, go to health insurance and the government. So this is the pools here. And the government or the health insurance pool make a policy that the primary care is paid by capitation. So the health center is paid if you have on 10,000 members, that means you will be paid 10,000 multiplied say $5 per people. So that means per member you have 50,000 US dollar per year for one primary health care. And then also the hospital can be paid by DRG and budget, global budget, something like that, based on DRG. Okay, this is the way of paying the hospital. So this is the first stage of payment. Okay. Then which one is better in terms of quality, efficiency, and equity compared to fee for service? What do you think? It's not easy. But the medical doctor responsiveness, what do you think about it? Or hospital responsiveness? If the capitation is too low, yeah, then the organization also they don't like it, yeah. Maybe they will opt out from the system. In the Indonesian system, there are some examples of regulations. Private hospital, they choose to opt out from the public health insurance because the payment is not good and it makes the hospital becoming making loss. So they pull out from the collaborations or the working together or contract arrangement with health insurance scheme. Because the private hospital is voluntary to join the public health insurance. Okay. Okay. Now we go to the paying the doctors. How to pay the doctors? This is very important issue in the micro clinical process. Will have direct impact to micro through some option of fee for service, salary, capitations, and remuneration system. So this is the financial arrangement of how to pay the doctor. And then using fee for service. So doctor will be paid based on how many services he or she provide for the hospital or primary care. Yes, it is a market forces mechanism, but it is different in making standard of fee. For example, for the senior doctor is different for the junior doctor. But doctors are happy. The income depends on the productivity, and also patient satisfaction is also high because the doctor has more attention. Yeah, usually. Yeah. Okay. But there are problems, tendency for supply-induced demand. So the patient actually he or she doesn't need, for example, ultrasonography, for example. But because the doctors they have like percentage of fee from ultrasonography, that means the doctors try to induce the demand. Although the doctor knows that the patient doesn't need this kind of equipment or the patient doesn't know, so they try to put the patient through the examination and the doctors will have some economic incentive. That this is the supply-induced demand. And that means increasing health cost inflation and difficult to have a proper budget. The higher income group enjoy better care, and the poor will be marginalized because the higher group they will pay more. Yeah, so that's why they have two solutions like UR and the food insurance. And this is one of the things that in some cases the doctors and the hospital cross the line and becoming intentionally making what we call like a fraud, that is by intention do the things that actually against the law. Yeah, because this is the point of supply-induced demand. So this is why there is a different knowledge between doctors and patients. Okay, And B, salary from the doctor, a monthly payment from the doctor, and then it is not influenced by economic incentive, planning is easier. But if the salary is low, there is a problem of productivity and also responsiveness to the patient. They're becoming lazy to treat the patients, and maybe if the public hospital, the salary is too low, then the doctor is trying to make a moonlight job in private hospitals. Yeah. Or this morning, in the Martian case, like a brain drain to the private hospital because the salary is so low in public hospital and there's no more financial incentive. Capitation, it is paid by the hospital or health services to doctors. How many members of one doctor can provide services? Okay. The problems are the negotiations, and doctor attention may be low, and then patient satisfaction also tend to be low and excessive referral. So doctors tend to make easy referral to the hospital because if there are too many patients, they will be very becoming burden to the doctors. And the solution also the UR and quality assurance and complaint management. The remuneration, this is like a formula, mix of salary, fee for service, and bonuses for good performance. The minus cost of treatment and income tax. And this is the thing that now is becoming more and more popular for paying the doctors. The problem is difficult to make a fair formula between anesthesiologists, ophthalmologists, and GP, and somehow some doctors are not satisfied with the formula. And then conflict across human resources in hospital can exist. The solution also it is very micro solution. Better plan, use expert support and quality assurance and complaint management. Okay, I think we don't have time for this workshop. I think in your country there are so many ways of purchasing health service organizations and also human resources for health. Is that right? So please think about how to pay the hospital and public health centers and how to pay medical doctors, nurses, and other health service workers. Okay, that is the things that must note. Yeah. Oh, that's left. Okay. The risk of negative impact payment in quality of care. Fraud. Yeah. This is intentionally making a mistake regarding the truth for the purpose of gaining something of value at the expense of another person. So this is the thing that the micro level of health services is not what was like exempt from crime. That is the point that I will make. So fraudulent people who make fraud attempts to obtain personal gain. And the definition of fraud varies depending on legal jurisdiction. And usually fraud is more rampant in the way of doing the payment using the claim system, you know. Like health insurance claim is similar with the insurance in motorcycle or house. So fraud in health insurance is the same origin with fraud in any insurance. Yeah. So that's why in country that use a lot of claim system, there should be like a very strong regulations on how to prevent and eradicate fraud. Yeah. And that's why it is called a white collar crime and has an impact on public and private health payment system. So this is not only for private, also in public hospitals. And in the US, healthcare fraud is the dominant factor causing soaring healthcare costs. This is the point. Okay, so this is the possibility. So that's why, if we look at back to the examples here, there are so many things that can be falsely done by the micro system at the hospitals or healthcare, from influencing patients to induce demand, bill for services that were never made, phantom billing, yeah. So many things here. Okay. So, at the closing, the policy at macro system level can influence meso and the micro level. At least the point. That's why after this session, there will be a session on regulation, on licensing, on quality, and many things. So the intention at the macro level is good. Yes, we have to think about equity. We have to think about the humanitarian value of medical care. But when we go down, because this financial arrangement, purchasing and payment, there's a possibility of having a crime or inefficiency in medical service. So that's why needs a well-functioning good governance. And one of the important issue in governance function is the accountability. Governance structure and mechanism, rules and process for health sector organizations, independent, oversight, monitoring, and this review and audit, transparency and openness to scrutiny. So this is the thing that maybe Prof. Adi Utadi will explain more in quality and also regulation in health services. Okay, thank you very much for the attention. See you again in the next session. Thank you.
So we have a tea break just outside the room here, and we'll reconvene back here at 3:30. So feel free to walk around and have a drink.
technically, yes, we have to go down because it influences like the micro system. So that's why for next year, we have to stick on this private technology. And then we have to announce a year before. Yeah, and then we have like time for the participants to learn from our website or they come to that.
there's one group which is smaller, so I think it can't be a group, but never mind, it doesn't matter. So we have got 5 groups, and you have got 3 days. So later on today at about 4:30 or whatever, we'll have 1 hour, and there are tutors that will be taking each group. So for today, the first question would be to identify challenge issues in integrated care, in the engagement of private sector. We suggest that maybe each of the group can take one country or region, but you can discuss all the different regions as well. So there's no limit. Then the second day, tomorrow, you would be then looking at the options and strategies, right, using those instruments. And the third day, you present, right? So you need to identify one person in your group to take the notes so that you can look at the issues, the options and strategies. So you present tomorrow on the last day. And on the last day, there'll be discussion, and Professor Sophie Chen, who was the previous Secretary for Health, has very kindly come to moderate that session. Right? Okay, so the suggestion is that maybe for group 1 to talk about Indonesia, you can use a starting point. But if you want to talk about the other countries or regions, you're free to do it. We suggest that at least you starting point to look at that. The second group would be Hong Kong, SAR. The third group can look at Singapore. The fourth group could be China, and the fifth group Taiwan. Right? But of course, sometimes you may not be familiar. But if you want to raise other issues about the countries that you are representing, you can do so. But we suggest at least to start doing this. Right? So you can either talk about one specific country, or you can look at the different mixes. So it's entirely leave it to your discussion in your group. You're clear, all right? So we're suggesting the countries, but you're free to discuss other places as well. Okay. Thank you.
Ten minutes, yeah, 10 minutes.
The final day, we suggest not each group 10 to 15 minutes, preferably 10 minutes, right?
10 to 15 minutes, yeah.
10 to 15 minutes. Yeah. I don't know.
Bapak Ibu peserta
Okay,
yang
so
ada
your question
online.
question of the private health sector. Thank you.
Oh, oke. Saya akan menjelaskan di dalam grup chat terkait dengan tugas kelompok. Terima kasih.
Right. So good afternoon to all. How are you? Cold. Yeah. A bit cold. Okay. My name is Anji Utarini. My friends at home called me Anji. No. My friends at home called me Uut. Sorry. But Uut is a bit difficult to pronounce, isn't it? So some call me Anji. Yeah, that's right. And I'm working also in the same department with Prof. Laksono, with Pak Mubashir. Regulation, and just to pick up from Prof. Laksono's last point, which said that incentive could influence providers' behavior. So in this last session today, I will be talking about what else could influence people's behavior. And in this case, we'll talk about the regulation part of private health sector. Now, I want to start by saying that, how do I say, in our daily life, daily life, at the office, at home, actually, regulation maybe is not a, it's not a favorite topics. When you deal with your children, for example, you have children, you know, you don't want to make a lot of regulation getting up at 6 o'clock and not using the mobile phone for more than certain hours a day, you know, all this regulation. But yeah, now, anyway, now we are supposed to discuss about the regulation part. Yeah, I'll skip this. Yeah, we'll talk about four things. First is the a little bit of just quick summary of Prof. Siripan already discussed in length about what is private health sector, and then some concepts related to regulating private healthcare, private health sector. And then the third point will be not exactly the case studies, because I think what I'm going to tell you is more of a story, and then how I reflect on these stories, and then we'll come to the summary. Right. Yeah. Whenever we talk about private health sector, am I allowed to go around or not? I'm aware of the camera over there. So whenever we talk about private health sector, I think what I would like to add is that it certainly is a very broad spectrum, and even sometimes it includes also the how do you say, from traditional up to the modern health sector. So in my country, for example, we still have a lot of dukun. Dukun is traditional healer. Yeah. You call it that? Oh, okay. Healer. Or, yeah. Healer. Yeah. Dukun, traditional healer. Someone without health background, no formal education on health, but helping so for certain services, like for delivery, newborn babies, or sometimes for giving eye care. There's a lot of also on the street, you'll see something like it can improve your vision without surgery or without drugs. So that also includes in the private health sector, which makes it more complicated, yeah, because we don't really know what's the standard, but somehow in the health sector, that is something that we have to deal with also. It can also be, how do you call it, non-healthcare facilities, but providing healthcare. So for example, in a hotel, yeah, hotel, if there is a small clinic in the hotel, this is the non-health facilities, but it gives some health services. Yeah, maybe it's a nurse working there or other way. So it could also be non-healthcare facilities, and I've talked about this is non-healthcare providers, but giving healthcare services. So all that also makes our life more complicated. And then we already realized that private health sector contributes a lot, yeah, even more than half worldwide, more than half of all healthcare delivered worldwide. This is given by private sector. So if I ask you in this room, raise hand if you have ever used private healthcare. Raise hand if you have experience in using private healthcare. Prof. Laksono, I don't trust you if you never gone through. Yeah, so maybe more than half also. Yeah, And this in this report, this is an interesting report, WHO Private Sector Utilization Report 2019 is quite recent, analyzing from 65 countries, probably the same reference that Professor Siripan also used. In Southeast Asia, it's nearly 60%, 57% of outpatient and inpatient services. A little bit more in Eastern Mediterranean, more than 60%, 62%, a bit less in the other regions, Latin American, Caribbean, and African Western Pacific. So it's certainly something that whenever we are talking about healthcare performance, we cannot ignore the private health sector. We must find ways to include them. And if we, if our role is we play as a government, then we need to include also this private health sector in all the programs that we are doing. Yeah. Yeah, if I look at Indonesia, also this is in Southeast Asia, three countries with the largest proportion of private sector medical providers. Indonesia here, total 60% of all care. Bangladesh 57.2, India. Let's see what's the largest. Egypt 75.2. No one is from Egypt. Okay. Pakistan 73.8. So that's also quite a lot. And then Indonesia, Bangladesh, India, and so forth. So I think this is the fact that makes it interesting for us to explore what are the different ways that we can try to influence the private healthcare providers by using regulation. Anyone knows this picture? This is Asian Games in, how do you pronounce this, Hangzhou? 2023. I think Hong Kong has a record of 53 medals. Is that correct? Yeah. Whenever we talk about regulation, I think it's easier if we think about a sport. Yeah. Cycling, tennis table, any sport. What is the most favorite sport here in Hong Kong? Jogging. When I look at the internet, it says football. Yeah, and you agree. You don't. Yeah. And I think whenever we talk about sport, we are never confused, about the regulation. I mean, we know, okay, we have a referee, and then there's a players. There's a clear standard for each type of sport, and you do not exchange the standards. You cannot use the tennis table standard for badminton, let's say. Cannot be applicable. So it's so clear. Information for both the players and the referees. They know exactly what is allowed and what is not allowed. If there's a doubt, then usually in the international competition, and they look at the video whether the ball is hitting the lines or beyond the line. So everything's, for me, quite black and white. But unfortunately, that's not our case. Yeah, in regulation of the private health sector and regulation in general, it's unlike the one we have in sport. And why is that? There are several reasons for that. First is that, we are dealing with life and death. It's not just about winning or losing again, yeah, but we are dealing with life and death. And yeah, though evidence-based medicine, for those of you with medical backgrounds, are we very familiar with that? Evidence-based medicine, any use of drugs, technologies, equipment, clinical procedures that should have a very strong base and should be done based on the evidence available. But at the same time, we also face that it's not so easy when it comes to promoting guidelines. Yeah, there's a good guideline already in an international consensus, but still it's not automatic like that everyone will follow the guideline. So yeah, medicine, I think for some is still perceived as an art. Yeah, you don't want to be told of what to give to the patients and how to work out the diagnosis. So that's the first reason. The second reason, I think I've already mentioned to you, large spectrum of East meets West. Yeah, we have the very traditional way of providing services up to very modern. In between, we have also, well, acupuncture is in Indonesia. I think it's in between, although I understand in Singapore, maybe it's already part of the modern care. The third, we'll talk about this a little bit more, is the policeman is not, the police is not enough, right? So we don't have enough regulators. There's a huge gap between the referees and the players. So with this huge gap, then many left to be unsupervised, yeah, or hidden. It's not so easy to find out. And then also, in some cases, there's a dual role, regulator and provider. In the morning, you work at the Ministry of Health. Yeah, you work as the giving oversight, governing, regulating. But then in the afternoon, you are a private practitioner. Do you have that phenomenon in your country? Yeah, yeah, yeah. Yeah. So I don't know. Is it easy? So long as you remember which clothes are you wearing, yeah? Whether you are in the morning as the officials or in the evening when you are the physician, or yeah. Yeah, that's looking at the individuals, yeah. But also from the institution point of view, like in Indonesia, Ministry of Health is also, how do I say? We have the vertical hospitals, teaching hospital, national level hospitals, and that is managed at the national level by the Ministry of Health. So do you see that as a potential conflict of interest with that system? Let's see. Let's see, yeah. We'll talk about more of the role, what's the role of the regulator and what's the role of the provider. Okay. Okay, so not so easy to walk around because then I have to keep coming back to the, can you hear my voice? Okay, so let's just refresh. I'm sure this is not new to all of us, but if we look at what do we mean by regulation? Regulation is you are exerting something to someone else, or sometimes also to yourself. Yeah, you want others to behave the way you want it, or the way that is according to rules and the standards. So it's imposing control using rules and principles. Yeah, for example, that traffic light, the green and the red is clear, but but the orange color sometimes is interpreted differently. Some people would just how do you say, drive the car very fast, when it's orange, but others, they are preparing to slow down and to stop. Yeah, so there are different behaviors. Now, in the Joint Learning Network, JLN is the Joint Learning Network for Universal Health Coverage. Here, regulation is broadly defined as imposition of rules. So it's the same keywords, but backed by penalties or incentives. So if you are good, if you're, I have one daughter, so so if she behaves the way we wanted, you can give incentives. Yeah, but then if she's not obeying to you, then you can use the penalties also. So to achieve what the objective is here is clear: to achieve the safety and quality of healthcare services, and also for the safety of the providers. I think it's good also to mention this, and this is, I think, one of the major lesson from COVID is that we may be not paying too much attention on the provider safety. Now, there is a term of regulatory agencies, which supposed to supervise whether health professionals or healthcare providers or organizations, it could be different level, whether they conform to the regulations. Yeah. Okay. Yeah. Well, now let's look at the process of regulation. What to regulate? What do we want to achieve by this regulation? Is it regulating entry? Entry means it's like when you want to start doing your medical practice. Before you are doing that, there's a certain regulation that you must meet. Or if you want to have your clinics, for example, in a certain location, then you also need to meet the regulations to enter the business or to enter the market. And then quality. We want to make sure that everyone who is giving care in an area, for example, they are providing high quality of care. Quantity. For example, if you feel like in the area there's already too many drugstores and you want to limit the number of the drugstores in that area, then this could also be a function of regulation. Price. Want to make sure that the price for example, for the poor socioeconomic level, it shouldn't be too high. So you want to control that price for a certain level. Distribution. Everyone loves to go to the city, wants to have their practice in the city, but then in some areas can be too crowded and nobody wants to go to the rural or remote areas. So this has to somehow also overcome with a kind of regulation. And then finally, competitive practices, competitive but healthy practices. So this is what we can regulate. And then who to regulate? Yeah. Who to regulate inputs is it could be the person, the professional, or the drugs, for example, also all instruments, inputs. It can be also at the organizational level, hospitals, clinics, different level of clinics, or to regulate the market. And then on the far left, you can see how to regulate. This is more of the mechanisms to regulate, either using legislation or, very formal one, or, more informal codes of conduct, incentives, and incentive regulation. Yeah. So I didn't want to read this for you, but I'm sure you've been familiar also with different things that we can discuss. One is the licensing, and then certification. A person may have a license as a medical doctor, but then he has special competence. Yes, I think for physical this advanced trauma life support, for example, for those working in the emergency. So they have certain areas that they are competent, and that can be certified. Accreditation, we'll talk more about this tomorrow. And then monitoring, oversight, through supervision, on the job training to ensure quality, networking, franchising. What is the franchising here in Hong Kong? Tell me. Well, Starbucks. Sorry? We could develop the regulations. Now, another way of looking the different regulatory mechanisms is by looking at the how do you say the degree of the degree of how you want to impose that regulation. Yeah? So types of regulation, it can be self-regulation. This is regulation by provider or professional groups setting the standards, their own. Yeah, for example, the medical association, nurse association, or different association, they set up their own standards, and they encourage, educate the members, and then they are doing that. So that's the self-regulation. Incentives is another type of regulations. Use of rewards, penalties, either financial or non-financial. I remember yesterday there was an incentive also. Well, maybe Hudiah, you receive incentive. So that's the award. And then the very strict one is the command and control. So this is the legal requirements. And when it's command and control, I think this by sanction for non-compliance. So yeah, I mean that is the consequences of if we are using this type of approach, the command of control, by having a certain law on that, for example. But what happens is that it doesn't matter whether you follow the law or not. Nobody is looking in that. Nobody is supervising you on that. Then it will not be effective. Yeah. So the command and control is already the highest, the strictest type of regulation, and it should be clear and it should be followed by any sanctions and punishment for non-compliance. All right. Yeah. So that is if we look at according to the ladder. But in this model, I think this colleague from Australia, they put a bit more detail into the level of the regulation, with the point that it's, well, according to him, it's better to start from the low moving up the ladder. I don't know. Do you that it's better to start with the lowest, for example, the voluntary. Defining that, and then you move higher to meta regulation, where you have several independent bodies to regulate, and then the higher is the legislation. What do you think about this? You think it's better to start the regulation on the low cost, low intervention, or is it better to start with the highest, which is the legislation? Someone from this table, maybe? Is it better to use the voluntary, asking people, educate people, and hoping they will voluntarily, follow whatever rules you want to apply? Or do you want to, it's better to start with the very strong? The first one, yeah, low. Or the first one from the top. From the bottom. So you prefer the voluntary mechanisms. And why do you prefer that? So if you can make it voluntary, that means, for example, I'll use accreditation. Accreditation in Indonesia is compulsory, mandatory. So let's assume that this is voluntary. It will work if what? You think this voluntary mechanisms will work, but under what conditions? Yeah, we have provide incentive. Okay, that's a good one. If you take this whatever international accreditation and you pass that, then we'll give government will provide facilities for training, extra training, etc. So it will work with incentives there. Yeah. Some regulations is better if the regulation is from the top. Yeah, that's I don't want to say that's very Indonesian, but unless that's really imposed by the strictest regulation, then people will do it. Yeah. Voluntary, I think voluntary will work, but with a lot of education, with a lot of dissemination, with a lot of good heart for everyone. So, for example, yeah, continuing education, using technology, using clinical guidelines. If it's voluntary, then it really needs the person to be well, how do you say, well aware of yeah. Yeah. While if you are using the command and control, then we want to make sure that everyone, regardless of whether they understand or not, but they have to comply. Yeah. I before COVID, I traveled to the US, and I was surprised that I don't see any policemen on the street. I say, how come? There's no policemen on the street. Well, in my country, in Indonesia, wherever you go, you will see a lot of policemen and police light men on the street, doing this regulatory role. Yeah. Yeah, this is just a few examples. How to apply this pyramid, yeah, of regulation, how to design the regulation using the bottom-up approach. Just for example, the voluntary one, for example, personally voluntarily engage in what? Our clinical audit activities, or performance evaluation activities, voluntary participation on that, any quality control activity, quality improvement in the hospital, for example. Performance-based payment, providing consumers with voluntary accreditation process. This would be self-regulation. Up to the that's the process of the regulation. Now let's go back to this dual role of regulators and providers. Now, I just want to say that regulators can be public and private also. Because you can, for example, have Ministry of Health or the Provincial Health Office implementing the regulator, but also have an independent body, private, for example, accreditation body, who is independent, private, and implementing the regulator. So this is the role for example, in one institution, let's say Ministry of Health, or at the local level, it's office is also responsible for the primary health. And then they have to implement the regulation for all types of facilities. They cannot prefer, for example, the public facilities and trying to over-regulate the private practitioner. That's unfair. They have to behave objectively using the standard. And then this will apply to all types of health providers. Consequences is the quality monitoring, and then they will report the result to the government. And of course, the persons who is doing this task of the referee, the regulator, they have to be trained as so in the early days in Jakarta, where the system for regulation is not yet that work is that you can imagine that if the hospitals is owned by senior in the area, yeah, senior physicians in the area, and then you go there as a regulator and you find out that they are not meeting the standards. It would be very difficult. It would be uneasy, at least uneasy, for the regulator to say that, sorry, your clinic is not meeting the standard, and therefore, if you cannot meet this in certain period of time, then I'm afraid we have to close your clinic. And that is something very difficult. There's and also for a person who is working or having the dual role, the conflict of interest can be real, yeah, because on one hand you are supposed to take care of the primary healthcare, for example, in the district health level, but then you have to make sure that the primary healthcare is good quality, but also that they can compete with the private health facilities. So there is a conflicting role in this functions of regulator and provider. Right. So I'll come to talking about the effectiveness of the regulation. And the story, this is about Yogyakarta. Yogyakarta is where we are from. UGM, Universitas Gadjah Mada, is located in Yogyakarta. It's a student city, tourism city. Those of you who love cultural tourism, cultural heritage, you should come to Yogyakarta. About population, about 400,000, bit more than 400,000. Good health indicators, a good place to spend your for the elderly. So a lot of people working in big cities, they'll come to Yogyakarta for the rest of their life. And again, access to healthcare facilities is quite easy. And this is a urban area, yeah, in this place. Now, let's look at in terms of the healthcare facilities in Yogyakarta. If we look at the burden, the volume of the healthcare facilities in Jogja, we have 18 hospitals, 18 primary healthcare centers, and then clinics 107, dental clinics 102, specialty private practice, so specialty physician private practice 71, midwife nursing private practice 18, 12 lab, 136 pharmacy, 19 drugstore, and then we have a lot of integrated health posts at the community level. So that's, if we add up all the number of the health facilities in that city, that's quite a lot, isn't it? Yeah. Yeah, that's quite a lot, and that shows the burden. If we want the regulation, then we how are we going to monitor and how do we know that all these healthcare facilities are meeting the standards and providing quality of care? There needs to be a system built for that. Yeah, and this is the consequences of the regulation. And if we look at what's in the district health office or the municipality health office, sorry, I know it's too small, but just want to show you that the district health office has 4 departments: human health resources, public health, disease control, and then healthcare services. And who is in charge of regulation? It's everywhere. It's it's scattered. Depends on what are we talking about. Are we talking about drugstore? Are we talking about street food, street restaurant? Are we talking about clinics, hospitals? These are scattered in the organization. And number 2 is that the number of persons in the municipality health office is very few. It's very few. Yeah, compared to if we think about the number of healthcare facilities that we have to govern, we have to regulate. Sorry. Oops. Yeah. Compared to this is very few. Very few. They have much higher education level than those who are working in the city health office. So there's a gap in terms of number. There's a gap in terms of education also, with less and less physician working in the district health office. So this becomes the challenge to do or to implement the regulations. So what happened was that in 2004, the innovation was to set up an institution, to set up an agency for doing this health service quality regulation, yeah, healthcare quality regulation. So because in that setting, without having a clear team, a clear agency on doing that, then the government don't have the capacity to do that. They don't have the enough capacity and also enough resources to do that. And if we let that situation going on, then regulation will be becoming less and less effective because no one is really looking care of the regulation. And now the agency is still there, and now it became the 2023. With the role is a bit because nowadays there's a lot of dynamics in terms of the regulation in innovation, a lot of new roles, a lot of changing in shifting in roles, so that with connectivity. So all the they are working in supporting the government. So just to implement regulation so that it can be more effective. So this is the first one. And when the agency started, they actually doing all sorts of regulation, licensing in place, and then nobody is monitoring the quality of the health facility. Almost 20 years ago. private practitioners do you have in this area? That's already difficult. With private, so many are unknown. So that's the situation when it was started. Especially BPJS in Indonesia, the social insurance require its license conducted by BPJS and not accreditation. Now, I think this is one push, yeah, from the system so that the health and healthcare give more attention. First reflection. The second reflection is that this is on another subject, and I think we all know that TB is high burden. Indonesia is number 2, so very high burden. And with the situation that a lot of source of care are from the private health sector, then obviously there needs to be something to do to work with, to engage the private health sector. And I was personally involved in this when the country is starting with a pilot project. It happens to be in Yogyakarta also. And at that time, we had to do this survey of private practitioners. The health office was not adequate to capture how many are working as private practitioner and who is having the, we don't know who is patients only in the primary healthcare. Health sector is a good area. Yeah. So when it started to involve, I think the strategy was started with hospitals first. And then later, and even the recent report 2022 said that up to now, engaging the private practitioners is still a big challenge. Here I quoted one of the dissertation from colleagues here in Bandung. They said that often when we started to engage the private practitioner, we think about the system, we think about procedures, we think about who is doing what, who is reporting to whom, how do we get access, but one of the important things I think is about building relations. Yeah. Between the private, I think the relations between the practitioners in these two offices are very, very important to build. So often we too much giving attention to the technical part and giving less attention to linkages, relationship between those working in the private and in the public. And this, in fact, is very important for getting trust, yeah, when we work with the private health sector. So many things that we need to consider. We need to, engaging them. We need to listen also to them. How do they perceive about the guidelines? How do they see about the patient factors, interactions between the hospital and the physician in the primary care, for example, the public health center and those who have the private practice in the same area. So incentives on resources, how would it be beneficial for the private practitioner? And what kind of resource, yeah, etc. And if we want to improve the private health sector, not just supplying regulation, but all the we want to regulation for improving care provided by private providers. So, well, I think that is also probably why we are all here talking about all the different aspects if we want to make it integrated in a way. All right, so I think I think I'll just come to the summary. I wanted to say that implementation of the regulation for the private health sector, I think it's a huge, and to be effective also we need to identify who are the actors having multiple actors and not also using one. And also, especially the government, so regulation and engagement of private health sector. Like effectiveness of regulation in this is integrated as part of the programmatic efforts. Or public-private mix, I think one of the initiator is the TB program. So many health programs, and if we did just one by one program, it will take forever to develop this. So we need to make these regulations effective to provide quality for all. So by that, I'd like to end this session and thank you very much for your attention. Good afternoon.
So thanks for all speakers' presentations. So we now move on to the group discussion. We have divided you into 5 groups, and we have the tutors at the back, and then they will go to your group and then to do the discussion according to Professor Yo guidelines. Okay. Do you need a notebook on your table? Or you can use you feel free to use the whiteboard or the maps, or if you need, we can give you one notebook for each group. If you want it, then just go back to us and then we can give you the notebook. So the discussion will last till 5:30.
And then more we can talk about okay. Sorry,
Halo, selamat sore Bapak Ibu. Mikrofon mana nih? Oke, terima kasih semuanya sudah berpartisipasi dalam grup WA. Saya cek dulu Bapak Ibu masih masih bernyawa nggak di sini. Nah, jadi coba tes. Suara saya terdengar ya, Bu Bu Tati?
Terdengar, Dokter Liga.
Oh ya, oke ya, matur nuwun Bu Tati. Bapak Ibu semua, terima kasih masih stay sampai sore di sini. Saya tahu ini pasti challenging juga buat semuanya, dan terima kasih sudah berpartisipasi dalam diskusi yang dengan Pak Mubashir ya, yang memang menarik ya kalau dilihat dari sudut pandang sebetulnya yang perlu integrasi layanan primer itu siapa. Bisa jadi mungkin BPJS yang butuh ya karena butuh efisien, tapi bisa jadi memang masyarakat yang butuh. Oke, ini sekarang saya mau membahas ini sih, gimana untuk diskusi kelompoknya. Ini kan Bapak Ibu sebetulnya ada berapa ya Mbak nilainya? 24 orang ya?
Iya dok, 24, tapi nggak semuanya ada sampai sore ini, jadi kemungkinan ini cuma 11 kalau dari pesertanya.
Oh, 11.
Yang hadir
Oke,
di
oh ya, oke. Nah, berarti saya juga ini. Berarti ini saya mungkin membagikan kelompok berdasarkan ini aja ya. Berdasarkan urut absen di sini gimana atau selang-seling? Apa ya? Jadi mungkin Dokter Zikri kelompok 1, Bu Elia kelompok 2, Bu Eva kelompok 1, Pak Gromiko kelompok 2. Mbak Anita mencatat nggak, Mbak? Bu Laila
ulang
tuh
lagi
nomor
dok, tadi
1.
pertama yang kelompok 1,
Oh ya, ada Dokter Zikri,
terus 2,
Bu Eva Sulistiawati dari Pusjak UK. Kemudian Bu Lailatul Izzah Abdullah.
Betul Iza,
Kemudian Miss Baudin, ini Bapak aja, Bapak Miss Baudin. Bu Nur Laila Marabesi. Sama Bu Siti Halimatul. Oke, kemudian yang kelompok udah Mbak.
Iya sudah. Kelompok 2.
Ya. Kemudian kelompok 2 Bu Elia Edres, Pak Gromiko, Bu Lucy Francisca, Bu Nova, sama Bu Nurul tadi belum ya?
Belum.
Bu Nurul dan Bu Tati.
Ya, totalnya 6 dan 6.
Ya, oke. Oke, sip. Berarti bentar, mungkin saya share screen dulu. Saya ini aja sih, share screen terima kasih tadi Mbak Dita ya. Mbak Dita udah share, Mbak Dita yang hadir di sini. Jadi kita, saya nggak bisa share
Kirimkan
screen.
nama-namanya di grup nih.
Oh ya, oke, terima kasih. Tadi Bapak Ibu, maaf saya nggak bisa share screen dan hostnya di dalam. Jadinya ini mungkin saya kirim aja ya di chat. Yang tadi udah didiskusikan, tugas kita itu ada, atau sebentar, saya tak bilang untuk buka akses. Ntar. Oke, Bapak Ibu, ini tadi ini adalah apa yang akan kita lakukan untuk 2 hari ke depan. Jadinya tadi kan ada beberapa pembahasan ya. Mungkin saya izin recap sedikit, terutama yang sesinya Prof. Ike. Kok tadi Prof. Laksono kan sudah menampilkan ada kerangka ya, kerangka untuk public private partnership. Bentar, saya ada slide-nya enggak ya? Ini dia. Sebentar, ini live ya. Oh my God. Nah ini tadi, jadi emang tujuan kita mungkin kembali merecap apa yang tadi diskusikan di WA bahwa ya kita refleksikan lagi kenapa WHO kok heboh menyemangati untuk public private partnership padahal mungkin di pemerintahan tidak atau kurang. Kenapa harus sampai WHO yang menegaskan gitu? Ya mungkin yang pertama karena kan mungkin WHO juga yang bukan WHO sih ya, sebetulnya kan pada dasarnya kita inginnya kesehatan itu sama rata, equitable seperti di sistem building block. Nah, untuk meningkatkan coverage dan lain sebagainya, ya melihat kenyataan seperti tadi bahwa misalnya 60-80% masyarakat di negara berkembang itu mengakses private sector. Nah, kalau sampai private sector itu tidak diajak main bareng sama public sektornya, tidak diajak berkontribusi dan kolaborasi dalam pelayanan kesehatan, bisa jadi universal health coverage-nya itu tidak betul-betul universal. Jadi memang hanya pelayanan tertentu di fasilitas publik dan benefit package atau manfaat yang diterima oleh masyarakatnya terbatas. Nah, itulah kenapa membutuhkan private sector engagement yang keinginannya kalau misalnya meng-engage mereka ya semakin luas pelayanannya. Nah, ini adalah konseptual framework untuk engagement. Ini frameworknya bisa kita pakai untuk menilai sebetulnya sudah seberapa jauh sih wilayah kita, daerah kita sudah menerapkan yang namanya private sector engagement. Ini bisa dikatakan sebagai kerangka pikir ataupun ya cara penilaian ataupun juga untuk kita di penilaian untuk diri kita sendiri, untuk di daerah kita sendiri seperti apa, untuk di Indonesia seperti apa, dan bahkan untuk sampai di tingkat provinsi atau kabupaten kota. Ini yang tadi dipaparkan tadi pagi. Nah, di sini salah satu intinya adalah adanya makro dan meso itu ada di sini enggak ya? Bukan saat yang ini. Ya, jadi kembali ke sini ada beberapa. Oke, di sini ada beberapa aspek yang dilihat. Ini mirip seperti isi sistem building block. Kalau Bapak masih ingat dan familiar, di sini ada service delivery, ada financing dan resources, kemudian ada pembiayaan dari mana, terus mekanisme pembiayaannya bagaimana, dan ada funding dan pooling. Di bawah sini juga ada beberapa aspek seperti governance, tadi ya, regulasi, kemudian juga SDM, teknologi kesehatan, sistem informasi, dan lainnya. Mungkin kalau buat saya sendiri sih apa ya, di sini di assessment ini kenapa besar sekali aspek financing daripada yang lain-lainnya. Kok bisa diperhatikan ya, kan health system building block itu aslinya sama besarnya, ada 6 unsur, tapi di sini kenapa lebih melihat banyak financing? Ada yang kira-kira mau ada ide? Oke ya, nanti ya, sambil jalan kita akan melihat ya kenapa kenapa sih ya dibicarakan masalah uang lagi ya, memang karena memang untuk memberikan pelayanan kesehatan tadi yang disebutkan oleh Pak Mup, private sector itu eh, pasti dia ada salah satu ya pasti keinginannya untuk mendapatkan untung, tetapi dengan efektif dan efisien, memberikan pelayanan yang terbaik, tapi juga mendapatkan keuntungan. Nah, sehingga mereka akan sangat peduli dengan yang namanya efisiensi, kemudian bagaimana melakukan performa yang terbaik dan lain sebagainya. Dan untuk mengengage private sector untuk memberi pelayanan publik penting untuk dapat ya supaya mereka ya win-win solution aja, bagaimana supaya mereka tetap happy dan publiknya tetap happy supaya semuanya bisa senang lah, puas dengan apa yang dicapai. Terus oh ya, kembali ke tugas, mana tugasnya? Nah, ini tugasnya. Nah, di hari pertama ini, di sisa waktu ini, silakan Bapak Ibu diskusi. Ini bisa breakout room nggak ya? Bisa kayak ini ya. Di breakout room yang kami sediakan. Atau mungkin kalau mau bikin grup WA sendiri juga boleh kalau misalnya lebih fleksibel. Tapi kita akan setup breakout room sebentar lagi. Di hari pertama ini, Bapak Ibu bisa identifikasi tantangan tentang integrated care dan engagement of private sector dalam satu daerah. Bapak Ibu silakan nanti di 2 kelompok. Saya nggak tahu nih, kayaknya anggotanya ada yang nambah nih, dibagi aja. Kalau misalnya satu kelompok 6 orang aja, jadi misalnya udah lebih dari 6 orang, dibikin kelompok baru saja. Silakan masing-masing kelompok nanti mengidentifikasi tantangan apa sih untuk melibatkan sektor swasta untuk dalam pelayanan kesehatan di kabupaten atau di kota atau di provinsi tempat Anda tinggal, tempat Anda bekerja, atau di tempat mana saja yang Anda inginkan. Gitu. Salah satu contoh kalau Bapak Ibu googling tentang private sector engagement, misalnya di pelayanan TB, silakan nanti siapa yang mau pakai kasus TB, pelayanan tuberkulosis ini kan tidak ditanggung BPJS, tapi selalu ditanggung oleh pemerintah melalui program vertikal di Kemenkes. Obatnya dibiayai oleh Kemenkes, pelayanan sehari-harinya ya diasumsikan udah tergabung dalam kapitasi. Nah, ada salah satu tantangannya dalam pelayanan TB adalah yang private practice ini kurang terlibat. Mungkin kurang terlibat atau memang tidak ada skema yang dapat memotivasi mereka untuk ikut serta memeriksa dan merawat pasien TB. Nah, itu contohnya. Nanti bisa jadi di tahap pertama ini, Bapak Ibu bisa memikirkan, yaitu tadi pertama, topiknya apa dulu, bisa pilih salah satu penyakit atau secara umum juga boleh. Cuma saya pikir kalau kita fokus pada satu penyakit akan lebih mudah dan lebih luas, lebih fokus dalam identifikasi aktornya siapa saja. Nah, kemudian setelah bisa identifikasi topiknya, tadi misalnya mau TB atau diabetes mellitus atau hipertensi atau penyakit tadi kesehatan jiwa tadi yang diberi contoh oleh Ibu Bu Enang Sumiwi atau tadi dari Bu Nurul Janatun juga menanyakan bagaimana dengan ILP, integrasi layanan primer. Nah, ILP itu kan ada 3 klaster. Nah, itu klaster bisa dipilih sendiri-sendiri, bisa seluruhnya. Kira-kira apa tantangannya mengengage private sector dalam pelayanan kesehatan. Jadi pilih topiknya tentang apa, kemudian yaitu identifikasi tantangannya apa untuk melibatkan sektor swasta dalam pelayanan penyakit tersebut. Apakah ada yang mau diklarifikasi? Oh, ternyata, halo. Oh, ternyata kelompoknya 17 ya. Oke. Oh, ini berarti yang kelompoknya saya revisi dikit ya. Saya bikin ya halo, silakan. Mbak Nila, saya izin edit dikit ya kelompoknya. Aduh, maaf. Please ignore. Gimana caranya ya tadi? Bentar.
Balik ke
Ya, ini saya tidak ahli dalam copy paste. Kelompok satunya sampai sini. Tiga. Kelompok kedua. Dua. Malah kelompok tiga ya jadi paling banyak, tapi nggak apa-apa. Oke, ini kelompok yang sekarang yang ini aja ya, Mbak Nila ya. Bentar saya hapus. Delete. Gimana, ada yang mau ditanyakan Bapak Ibu? Tadi Bu Nurul sepertinya udah buka open mic. Oke, kalau belum ada, kita coba bagi breakout room ya, sebentar. Saya bisa bikin nggak ya? Halo Bapak Ibu, silakan join room masing-masing.
Belum keluar dok itu untuk record roomnya.
Masa sih? Ini udah tuh. Bentar, belum ya? Saya udah bikin. Gimana caranya sih? Ini udah di assign. Udah kok Mbak, kayaknya. Udah nih,
iya,
udah
Dok.
tinggal kita doang.
Oh iya, pantesan ini kok aku nggak ada.
Iya, kita nggak masuk. Iya. Oh Mbak Nila mau desain?
Enggak nggak apa-apa. Ikut kemana ya? Kayaknya nggak apa-apa deh di sini dulu.
Mbak Nila jadi co-host berarti ya. Yang bisa jalan-jalan tuh co-host ya?
Host nggak sih? Atau kok host?
Oh masa?
Oh, host bisa.
Ya, ini in case mungkin waktunya sampai saya juga harus diskusi juga soalnya ini di sini.
Oh iya.
Waktunya bebas sih kalau misalnya masing-masing kelompok sudah memutuskan cukup ya silakan pada live breakout room gitu aja. Kalau ada yang mau ditanyakan bisa ini ya.
Bisa balik ke main.
Oh ya mereka kan udah di ini ya. Berarti caranya broadcast message ya?
Iya.
Gimana sih saya ini? Gimana caranya broadcast?
Ruang diskusi. Atau
Oh ya udah di chat ya. Silakan Bapak
ini
Ibu
apa kok ada 2?
berdiskusi.
Itu yang belum masuk. Oh,
Sampai jam berapa ya? Sampai jam ini di sana jam berapa Mbak?
di
Jam
sana
6,
di sini
4.
jam 5,
Udah jam 4.
5:05.
Astaga.
5:54 lah.
16.15 gitu ya.
Iya 15.
Kemudian
15.
bisa
16.
perlu kembali ke ruang utama nggak ya? Perlu aja ya.
Mungkin nanti dicek satu room per room aja dok. Maksudnya kayak pas jam 4:15 itu mungkin dicek dulu udah atau belum.
Iya.
Kayak make sure. Oke.
Oke, makasih ya Mbak.
Sama-sama dok, makasih.
Oke, saya tutup mic dulu ya.
It's lovely to see lively discussions. Unfortunately, our time is up for today. For those of you who are staying in the Alva Hotel, the shuttle will be departing at 5:45. So please go down to the foyer, meet at the entrance. Your shuttle will be waiting for you.
Oke, selamat sore. Kita tutup ininya ya. Yang di sini juga udah tutup soalnya.
Iya dok, ini ditutup untuk semua orang dulu.
Ini nggak usah presentasi sih.
And for tomorrow, we'll be starting in this room at 9 o'clock, 9 a.m. in this room. Thank you. See you tomorrow.
Oke, selamat belum ya? Udah. Oh iya, ini udah pada pulang. Oke, yang
5
penting
detik
udah
lagi.
punya topik masing-masing sih. Kenapa?